very honored to be asked to speak here. So honored. I have green and yellow on for the bison and the hawks of North Dakota. Today we'll be discussing the management of multiple medical conditions in dementia. I have no financial disclosures. I enjoy working at the Sioux Falls VA. I'm the program director of the USD Geriatric Fellowship. And if I say Pearl, it's my opinion. Most geriatricians, I think, would agree. But by definition, it's standards, strength of evidence D. Now, students, do not remind your attendings of this. If they say Pearl, you may not do well. Thomas is my favorite disciple. He was evidence-based, and he was able to change his mind. AI was not used in the creation of this, and this has coffee in it. What's in your water mug? My sources and journey, Google, I got my pictures there. The AGS literature, such as Geriatric Fingertips, the Geriatric Review Syllabus, the AGS meeting, and my temporal lobes. And she's discussed my journey where I learned about human nature and about elders. Objectives today, we'll discuss the approach to treatment. Historically, I think it's been more disease-based. Now we're getting to more of a person-centered approach. Discuss what matters most, multiplexity, dementia, and longevity. Discuss clinical practice guidelines, or at least how I interpret them in dementia. Discuss some cases and answer some questions. The University of Nebraska, Dr. Potter, she's a legend in geriatric care, is the department chairman. She had a saying that just has stuck with me. Old people are different. It's a mindset to approaching the care of the elders. You talk about function, you talk about matters most. I just think you need to think in those terms. I think it's more than just a set of facts, it's a mindset. Well, 30 years earlier, Dr. Collins, our pathologist, he said the most important things are the age and sex of the patient because that determines what diseases you will see. In medical school, we were taught to be diagnosticians. We had to treat the disease. If there's an ill, we had a pill or a treatment. And that's how we were trained. And I think that mindset is seen in the literature of our charts today. This is a little bit of my soapbox. This is a review of systems on a consult I saw. Notice it's all disease-oriented, except there's two things. Weight. Weight is my favorite, vital, because it's a barometer of your overall health. And then this other one can climb stairs. There's actually a functional assessment in this review of systems. It also carries into the physical exam, which we template to make the coders happy. Times 3, general behavior, level conscious, blah, blah, blah. Oh, gosh. I hope that describes all of you, but it describes most of the people that come into an office. This also talked about gait. Very good, but the person that did this didn't actually clean up the template and say which one it was. On the other end of the spectrum in notes, we see the minimalist. When I've had my red ink for the geriatrician for comments, vitals are noted, and how many times we template the wrong day in. Is there a weight on there? Now, ANO, NAD times 3, ANO times 3, that is a low bar. I know who I am, where I am, and maybe I know the year, but they give the person gives the socially correct, light, but wrong or incomplete answers, and their wife gives the rest. HNT, we never look, within normal limits, but their vision is poor, and they forgot their hearing aids. Lungs are clear, but they're on oxygen. RRR, no MRGs, but they're too winded to walk to the exam room. Cranial nerves are intact. They move all their extremities, but they come in a wheelchair. 12-point review of systems is negative, but no ADLs or IADLs are mentioned. We're taking a picture of someone from 20 yards away. We just don't get very good definition of what's really happening. So now there's the age-friendly system. Looks at more the complexity of older adults, the multiple conditions, the sensory changes, mobility issues, variability in what matters most. It's person-focused rather than disease-focused. And these are the core issues that should drive care. And if you're doing everything for every disease, it sometimes gets in the way of their life. These core issues are what matters most: medications, mentation, and mobility. A few years ago, Dr. Reese told me we've also added multi-morbidity as the fifth M. So if you have an ill, we have a pill, and now we say, should you take it? Okay. Now the 5 M's need to be consistent with the elder. When I think about this, this goes back to the last century, when I was much younger then. Meds didn't coincide with what mattered most to the family on this gentleman. He was well over 80 and admitted to the memory care unit in a nursing home to my service. Probably used to fast 5 or 6 with AFib, RVR, GERD, hypertension, osteoarthritis, advanced Alzheimer's, all with appropriate med lists and treatments for the diseases. Well, his dementia progressed. Now he's a fast 6. He's not in the memory care. He just sits in his room now. And one day on rounds, his wife said to me, "Why is he on so many meds? He never wanted to be here. He doesn't know me. He doesn't like taking meds." Oh, okay, well, let's review the med list. Okay, he has AFib. He's on warfarin. That helps prevent strokes. Strokes! He has a stroke. He goes to heaven. Stop it. We went through the med list. And I think when we were done, when he stopped his PPI, he had heartburn. Well, he wasn't very communicative. He wouldn't tell us if he had heartburn, so we left that on. And the same with his RVR and his Deltizin. Everything else was gone. So I walked away. I thought, oh, she's blunt. Dan, why didn't you bring that up earlier? Well, you didn't know the family. Okay, but I hope at the end of this lecture, you'll take away a little bit of this, that this won't happen to you, that people tell you the right thing to do down the road. And you should have brought it up yourself. So here's your new patient. Consultation for geriatrics. 75-year-old lady comes in. She has Felty syndrome, which is basically RA with some more immune problems. She's a fall risk. She's had 2 falls in the last 3 months, so she wants some PT. Gout, insomnia, they're basically stable. Her thyroid is a little low, so she wants a little more thyroid. Hypertension's controlled at about 130 over 90. Significant osteoporosis. She's on denazinab, and you need to get that taken care of. So with her new insurance, and osteoarthritis in the feet, you want to keep her mobile. You have to have good shoes so she doesn't have blisters. See podiatry. She had a lot of surgeries on her back. She has the MRI schedule, so see your surgeon. Okay, fibromyalgia, that's on the problem list. She doesn't mention it, so we don't ask. Mugus, you've looked at that, and that's not up to date. That needs to be brought up to date. She knows her colon needs to, she has that scheduled. Incontinence, she says, we're not doing anything. I'll get back on my exercises, get my cream. Sleep apnea. Now that, if she would tolerate CPAP, I would say that's going to be good for you, even at 75. Unfortunately, she doesn't tolerate it. Constipation, obstipation, we have come up with a bowel program. Social stressors, mention your social worker, going to get some mental health follow-up. Back surgeries, she has a Moses's staff she walks with. Now her hearing, her vision, and her cognition are normal. Just has the staff. And what matters most to her is to have some time with her grandchildren. And she's an interesting dream, right? Complex problems, a lot of balls in the air. It's kind of fun, cognitive challenging. She does what she needs to. She has the capacity. But we want to keep it safe and simple because she has a life to lead outside of my office. Which brings us to Dan's niche theory. An animal in the right niche will thrive. He's enjoying the sweet smell of the eucalyptus. In other niches, survival is determined by adaptability. Now, an elder in the right niche will thrive. Elders lose adaptability, so that niche gets to be a little smaller. But what is the right niche? Who decides? Well, Curly in City Slickers, what matters most? What's quality of life? What's the right niche? He says there's just one thing. Go figure it out. Well, that's why we're here at this lecture. the right niche. And I think about Maslow's pyramid. It's a safe place. That bottom level, you know, have to be safe. You want, you know, heat, warmth, shelter, all that. What's the design? Is it user friendly for someone who's older and who will have changing health needs? It doesn't have a spiral stairwell like my grandmother's farmhouse. They can use adaptive devices. They can get assistance in the home. Hopefully, it's low crime and access to resources. The next step is we want to optimize their medical problems to what matters most to them. Get the meds right, the optimal treatments, the optimal diet. And then the next is your caregiver needs to understand your problems, and we have to take care of that caregiver and get them rest so they can be a good caregiver. Now, to understand the problems of aging, you have to understand slowness, you have to understand dementia, behaviors in dementia, hard of hearing. Here's an interesting term. I was hearing hygiene, how that I can speak to someone who's hard of hearing and do a good job of it, not just giving them hearing aids. Diabetes, heart failure, AFib, etc. If they understand that, you will do better. And the last thing is you have to have access to a healthy lifestyle. Good nutrition, exercise, socialization, access to your needs. Now, for some people, that's a very easy thing. You know, what matters most is realistic. The goals are realistic based on their disease, their function, their resources, and their support. And then there's the other ones, the challenging people where matters most isn't safe or realistic. They argue with you on wearing a bicycle helmet. They don't have social support, and then that ever wonderful symptom, anosognosia, where they do not know their limits. They do not think there's anything wrong. And for the people that are realistic, there's the thing one and thing two. Thing one, do everything that might help if it's easy. Yeah, doesn't cost much. It's not hard. I'll try it. And then thing two, only do what will really help. You don't see many of those. Most people are thing one. And I tell people I'm a navigator. You are the captain. My job is to give you good advice, tell you where the shallow rocks and the sandbars are. But you sail the ship. You have capacity. It's your ship. You decide what matters most, and you decide where and when to sail. Now tomorrow, if you're on a sandbar, I'll get my tug and we'll pull you off, and that's okay. This is Captain Edward Smith. His priority was to make it to New York in record time. I don't know that he was listening to his navigator. That brings us to multiplexity, which is 3 or more chronic diseases. The original phrase I heard was multimorbidity, multi-complexity, multiplexity. I would rather be complex than morbid. I think multi-complexity is a better term in the office. It's 3 or more chronic diseases, and it affects more than 50% of older adults, and it has a distinctive cumulative effect on each individual. And it's associated with increased rates of death, disability, adverse treatments, institutionalization, use of healthcare resources, and most of all, decreased quality of life. And the approach to it, first, they're a very heterogeneous group in terms of the severity of the illness, the functional status based on their illnesses, prognosis, their personal priorities, risk of adverse events, and then you throw in cognition, which is a whole other dimension on all of these. And it requires a flexible approach because it's such a heterogeneous group, even if they have the same condition, so the treatment options may vary. But that's what makes geriatrics so much fun. Everybody's individual. It's a different set of problems we solve for everybody. Now, are there clinical practice guidelines for multiplexity? Not really. Most of them focus on one disease, and they try and get a homogeneous group to do the study on, which means multimorbidity elders are underrepresented in clinical trials, observational studies, so there's less representation, meta-analysis, systemic reviews, and then hence the guidelines. And some of the guidelines, if you do everything on the guideline, might be a little irrelevant or harmful and very, very expensive for the person with multi-morbidity. And the approach I have, this is out of AGS, there's 5 domains. First is patient preference. What matters most? Which disease is causing the most functional decline and the most quality of life issues? Interpret the evidence. What is it? Does it apply? Is it feasible? The more complex the regimen, the higher the risk of non-adherence. That's just basically systems thinking. The more complicated it is, the more chance it is for things to go wrong. There's adverse reactions, impaired quality of life, and economic burden, caregiver strain, and depression. If you can't do things right, that's hard on the psyche. And what's the prognosis? We want to frame decisions in context, the risks, the burdens, the benefits, the prognosis of each of the problems. I'm going to optimize therapy in terms of the prognosis, the benefits, the risks, and the burdens. And then the question I always have, when do you stop doing preventive medicine? That's not my choice, but it's one we need to offer. And it's an individual's decision. As you know, a lot of what we're doing is preventive medicine, for the outcomes of the diseases, or there's the secondary prevention because they've already had the outcome. There's controversies. First, the ever-changing health status of the elder patient, multiple clinicians and multiple settings. And for those of you who's dealt with doctors, does the phrase 2 doctors, 3 opinions, does that mean anything? There's need for multiple simultaneous decisions. There's a little bit of a data desert for how you should treat, a couple problems all at once. There's a scarcity of prognostic tools, sometimes with conflicting results. And we may treat one thing, but that may worsen the other. And then the other thing that's very difficult is it takes time to discuss this with elders and their family members and decision makers. Dementia. Now, where does that play in? It's a progressive disease with loss of function. And we need to take that into account when we think about prognosis. We're going to do just a brief overview and remind you of the various dementias. Alzheimer's is gradual onset, 8 to 10 years average. Cognitive symptoms, memory impairment is a core feature with difficulty learning, new information, language, visual, spatial. Behaviors tend to be a little later. Motor, as a rule, no. Vascular dementia can be a sudden or stepwise onset, progresses gradual or stepwise, depending on the ischemia. Cognitive symptoms depend on the anatomy of the ischemia. Dysexecutive deficits and slowing are common. Motor symptoms correlate with the ischemia. Lewy body dementia, I find this a hard one to treat because of the behavioral issues. The onset's gradual, progresses faster than Alzheimer's, typically often with visual hallucinations, REM sleep disorder, behavioral disorders, memory, visual, spatial hallucinations, fluctuating symptoms. And if it reads the textbook, the cognition should start about the same time as the Parkinsonism. And this isn't my personal experience. I've seen more paranoia and autonomic dysfunction with Lewy body, the Parkinsonian dementias, and the Parkinson's plus dementias. Frontotemporal, these people are hard. They're young. Cognitive symptoms are executive dysfunction, disinhibition, apathy, language, memory, not as much early on, and sometimes it's the behaviors that present first, no motor symptoms, and it progresses faster than Alzheimer's disease. Life expectancy, this is off the CDC website. A 70-year-old man, good health, probably live to be 88. Poor health, maybe only 77. By the time you're 90, good health, you might, make 96. Poor health, just maybe a year or 2. Women, who said they are the frailer gender? They outlive us. 70-year-old woman should live to be 91. She's in good health. By the time they're 90, 97. But this is a population we all know from dealing with elders that life is precious and also precarious. We do not know what tomorrow holds, and I saw this pulpit rock in Norway, 604 meters. I'm sitting at the very middle of it. If I'm even up there, we don't know how close we are to the edge on any one day. So we need to be thankful for that. Let's talk about just some guidelines in these various diseases. We'll go through them one by one. Dementia, this is kind of Dan's guidelines. For those of you on the front line, I've been there, identify it. It is not normal aging. I think society is starting to identify it more with the drugs that have come out, with the work of the Alzheimer's Association. People are asking about it more, tests that we can do. So I think that's getting easier than it was years ago. But it's not normal aging. We should need to discuss it. And we need to support the caregiver. And for those of you in small town America, this is hard because we don't have the resources. There's no senior center that has adult daycare, like there are in the larger cities. There aren't, it can be very difficult to get respite care out to someone, 5 miles outside of a town that only has one stoplight, like mine. So that's a little harder. Do get the advanced directives done. The sooner the better. We need to think safety, exercise, socialization, sense of purpose. We want to minimize the brain insults, alcohol, nicotine, the meds. We want to optimize their medical treatments, their medicines, their diet. And thank you, Dr. Martin. That was a wonderful talk, and I feel terribly guilty. We want to educate the caregivers so they can understand the diseases. And if you're treating with the dementia meds, by the time they hit fast 7, you should have stopped them. A caveat on dementia is depression. I was always taught back long ago, depression is a lifelong disease. But recently, it's more, you can get it as an elder. And I think, presents a little differently. It may precede the onset of Alzheimer's, and it'll accelerate dementia. If someone stops eating or withdraws, you really got to think about it. I think the chronic loss of function is really hard on one's psyche, and that gets you frustrated and anxious. Escitalopram and sertraline are generally good first choices. The escitalopram can raise your QT a little bit. I have had good success in following up, and the patient family says, yes, things are a little smoother at home. Now, quality of life in dementia is hard to achieve, but we can easily make it worse, right? There's denial, the wrong niche, it's not safe. They continue their bad habits, poorly treated comorbidities, no exercise, socialization, no purpose, the wrong meds, the regimen's too complicated, the caregiver is stressed out, and you've been in those visits, right, where you're refereeing an argument, or they have no caregiver at all, they haven't prepared for the future, and they get admitted to the hospital. Okay, we'll switch over to hyperlipidemia. And people love their statins. Now, for people over the age of 75, if you're doing secondary prevention, they've had a heart attack, a stroke, some vascular problem, the recommendation is to continue with statins because you get good mileage and on prevention. When do you stop, though? Not a lot of good data there. Now, the value of lowering the LDL in primary prevention in the person who's never had a heart attack or a stroke, the data isn't quite as good there. If someone doesn't want to start or wants to stop, you can make a good argument for that. And then when I discussed it, think, what is the time to benefit? What's the burden of the treatment? Popping a pill that's $4 a month, that's not too much of a burden. What's the prognosis for other multiplexity versus what matters most to you? If you're having a difficulty, I'm talking about de-escalating things, I'm saying order another test. Well, if you don't know what to do, and it's, yes or no, coronary calcium score, if that's very low, you think you can probably get rid of this. If it's fairly high, they may say, no, let's stay on it. There's some literature on stopping statins. There were 3 retrospective cohort studies. People over 65 had increased risks of cardiovascular events over the next 2 to 5 years compared to continuing them. But it was approximately 1 cardiovascular event for every 112 people who stopped a statin. I mentioned that to someone this week. I just learned this last week at AGS, and they said, ooh, that'll be 5 events in 5 years. That's kind of high. They wanted to stay on their statin. Okay. However, if life expectancy is less than a year, there is no increased risk. Hypertension. We've all been taught, we've been telling patients for years, lifestyle is the first thing. You know, high diet, good, plenty of potassium, low sodium, you know, the Mediterranean diet. Try and get that aerobic and resistance exercise in 90 to 150 minutes a week. Multiplexity and mobility issues, this is hard. Moderation of alcohol intake, limit 1 per drink per day. Someone has cognitive decline that's significant, I say none. We don't want to insult the brain. Smoking cessation, we've heard weight reduction, as you mentioned earlier. Some people have obesity with sarcopenia, and this is a real double-edged sword. Now, as far as pharmacotherapy, you know, base your treatment based on standing blood pressures. First-line drugs, your thiazides, ACEs, ARBs, calcium channel blockers. You know, follow up closely until it's maintained. Now, it may take 2 drugs. That's okay. And you can always think some of the other agents. I usually look at what other benefits do I have from the second agent, and then follow them every 3 to 6 months once they're at target. Now, for the older adult with hypertension and multiple comorbidities, limited life expectancy or both, I think we need to individualize blood pressure to consider the benefits, the adverse drug reactions, reflect their goals, and also what other problems are we dealing with. And if we're dealing with syncope, hypertension is a devil to treat. I think Mark, Dr. Dewey had a nice slide of the various recommendations of the different organizations on this. This one is just the American Cardiology and the American Heart Association. They say 130 over 80 is a good goal. And remember the SPRINT trial about over 15 years ago, it looked at really pushing blood pressure in older adults down to 120 over 80, or more physiologic for when we're young. But study wanted you to live at least 3 years. They excluded people in nursing homes, people with dementia, people with diabetes, syncope. And when you take that healthy group of community dwelling elders, yeah, you get less MCI, less cardiovascular mortality, but you also have more hypotension, and it only took in about a third of people over the age of 75 are eligible. Now, that doesn't mean the lessons learned don't apply to the person in the room with you who doesn't qualify for that study. Diabetes. You know, someone is in good health, functional, cognitively intact, you know, aim for that A1C of 7, morning blood sugar is 80 to 130, blood pressure, evening 80 to 180, and blood pressure 130 over 90, and a statin's indicated. Now, when you start to get the multi-complexity, you know, you got 3 chronic diseases, maybe 2 IDL impairments, mild or moderate cognitive impairment. You can let up a little bit, A1C less than 8, fasting's a little higher. They still recommend the same blood pressure for the statin. Now, when you get in poor health, now you're down to ADL dependencies, severe cognitive impairment. Recommend the A1C isn't as important. You can let blood pressure go up, and you really need that statin, and I would maybe argue that's that shared decision. Are you thing 1 or thing 2, and really how much do you want? It's case-based. You have to engage both partners. I think I really stress this to my elders. We want to prevent hypoglycemia. The brain has two fuels, sugar and oxygen. If we don't have it, we pass out. Now, the Hollies back in 1973, they said, all I need is the air that I breathe and to love you. They're musicians. We're scientists. We know you need sugar. And so we can't let someone's blood sugar go low. Otherwise, they pass out, they fall, they break something, something bleeds. That may be the last problem they have. And so low blood sugar, you can stop aging. High blood sugar, I think it seems to accelerate the aging process. So one thing you do is you can get rid of those small prandial rapid acting doses. That eases things up. You can get some scheduled doses. How can you simplify it with less checks? And if you can get a continuous glucose monitor for even a short period, that may tell you that your regimen doesn't have any lows. Now, someone has to be on tight control for healing something up. This is a Danism. I like to have glucagon at home. It's an insurance policy. You know, if someone passes out and you're calling 911, it's an easy stick. They may wake up. Depression. Siggy camps. You know, that's the sleep disturbance. Of course, you see a lot of that in elders for a lot of reasons. Loss of interest or pleasure in usual activities. You know, sometimes that may be due to other diseases besides depression, depending on what gives you pleasure. If you can't get on your knees, it's hard to do gardening. Excessive feelings of guilt or worthlessness. I'll see this in the nursing home. They say, why am I still alive? Decreased energy and increased fatigue. Well, that's very common. Diminished ability to think and concentrate. Yep. Appetite changes. Mood is low most days. You know, that's why you have collateral information when you're doing your history. Psychomotor agitation or retardation. And that's that frustration and anxiety that I see from lack of function. And then suicidal ideation. Now, elders, older men are high risk. They get her done, unfortunately. Now, depression treatment after the right niche. You know, I think give people some way to succeed. Give them a reason to get up in the morning. I think that will help, and I think our previous lectures have mentioned these. First line, if you're going to use pharmacotherapy, typically SSRI or SNRI. Second line, push the dose, add mirtazapine. Don't combine two serotonergic drugs. You know, in younger people, there's a lot of different things you can augment with. In elders, you can augment with a lot of things. Sometimes it's psychiatry consult if you're thinking about an 8 a.m. Antipsychotic. If it's purely motivation, the psychostimulants in low doses sometimes are quite effective. Weaning antidepressants. Well, if life is going well, the patient I've been caring for or the new patient, I tend not to change the regimen unless it's a high-risk regimen with high-risk drugs, or unless there's some physiologic change or health changes in some way, I'd want to consider a gradual dose reduction. Heart failure. When you look up the clinical practice guidelines, goodness, it's always the boxes pointing to everything, very complex. I think it comes down to manage the symptoms, which are shortness of breath, dyspnea, exertion, and edema. And manage the fluids with your diuretics, daily weights. And I think that's very important. And that you, back in my former life, I gave a lot of my heart failure patients sliding scale furosemide and potassium. Give them control of the disease. Empower them. I think that's very important. I think with heart failure, there's sort of a sweet spot of where your weight is, where everything works fairly well. You get too heavy and the diuretics don't work. You just gain a lot more weight. Too dry and then you don't get your preload and you feel lousy. So you want to keep them at that, and if they get a little dry, they can take less diuretics. They get they go to the bacon festival, they may have to double it up, double their potassium. If they go a cup for the whole weekend, they might be seeing you for the IV furosemide. Manage their heart rate, anticoagulation if they have AFib, because I say it prevents strokes, and strokes really cause disability. We're blocking renin, beta blockade, and ANI. Now they're expensive. We have good data. If their drug says gliflozin, they help too. But again, they're also very expensive. And don't forget the hospice and palliative care consult. If you're getting admitted a lot, your mortality is going up. Consult hospice and palliative care early. They like that. They get to know people. They can feel comfortable with them. And then when they really need them, it's a friendly face that understands and already knows them. Sleep apnea. My pulmonary colleagues tell me that if you have less than, less, it really doesn't help your cardiovascular risks if you have less than 5 years to live. And starting PAP therapy in dementia is oftentimes unsuccessful. However, if someone comes to me and they're early in the dementia journey and they want to do everything they can, I look for sleep apnea. If they say, yeah, I'll do it, I'll do anything, I think it's worth looking for. And then frailty, weight loss, sarcopenia, fatigue, lack of energy. Notice that definition doesn't include dementia. It's more like a functional issue. And you've seen this, when people are at that, 6, 7, 8, 9 stages, you really, I think, need to simplify their care and work on doing things that they can do. Okay, now when we try and de-intensify care, that does challenge your ability to practice the art of medicine. Now, the science of medicine tells us what is probably beneficial, but how, after we've been telling adults their entire life, we need to treat this disease. Now we're saying we may want to de-intensify therapy. One way to say it is this test will not help you live longer. Don't say you're not going to live long enough to get benefit. Doesn't sound good. Their thing is, if there's an issue, discuss it. Don't leave it on the table, because people they want to know. If they know a colonoscopy is due in a year or two, it's not indicated, you don't think, discuss it with them. That follow-up stress test, the mammogram, the PSA, the Preventative Task Force has guidelines on all this. So I say discuss these with people that they want to hear it. Pharmacology, deprescribing sounds better than stopping meds. The intensification, well, we're going to lower the doses, make it a little less work for you, less meds, less monitoring, easier life. Simplification, we're going to easier dosing, less treatments, less risk. And one of the docs at AGS said, he uses the phrase, I think it's time to retire this medicine. As an employee, it's not helping. Here's what works for you. Now, let's get to treatment. We know what matters most to the person. Years ago, a gentleman told me he didn't have multimorphexity. He had just 2 problems. Pancreatic cancer, and he'd aspirated in the hospital while he had pneumonia, and now he had it bilateral. He said, as long as I enjoy the company of my wife and my friends, it's full speed ahead. We got him out of our little hospital, and he had a good summer. I always remember that. What matters most to him. Have they done their paperwork? Encourage people to do that. Now, we know what's important. We know about what kind of health they're in. Let's discuss the burdens of care. Let's look for safety, what adverse drug events we're going to have with this med regimen. How's their adherence going to be? How are we going to do with their dementia? How is their caregiver going to do having to do all these things? So now we're going to start simplifying the fewest meds, the fewest times a day, and simplify the routines, both medical and lifestyle. Get their ADLs in a routine. When do they exercise? When do they go out? When do they eat? When do they sleep? If there's a question level of care, your occupational therapist can help you there. It's the Allen testing, the CPT testing. That'll give you, and sometimes the family, some enlightening information on what level of care would be best. And some helpful sites for pharmacology, Beer's criteria, the stop-start, e-prognosis, anticholinergic calculator. I like the one that's the ABC Calc. The HASBLED, if you just Google that, Chad's VAS2 frailty, you find out what your cardiac risk factors are for the static heart. And then also, if you Google choosing wisely, AGS, that gives us the 10, an explanation of the 10 criteria they have. All righty, let's talk about some cases now. We have a little time. Our lady that we saw, now it's been 5 years, unfortunately developed dementia, has an 81-year-old husband. Life expectancy is probably less than 5 years. Felty syndrome, rheumatology has been kind enough to de-prescribe and make that a little simpler. The dementia, she's on donepezil, memantine. We discuss this every year. She's still trying to go out and see the grandkids and wants to maximize, so we're staying on that. The fall risk still continues to be a fall risk. I think it's more important now. She's older, so we're really going to work on the OT, PT, strengthening, and make sure that she has the right assistive devices. We're maximizing hearing, vision. I think at this point, hopefully we have some home health on board to support the caregiver. Make sure you're monitoring the meds and the labs correctly, vaccinations, hypertension. There's no syncope. I think you can stay at the current regimen. The osteoporosis, we've been doing that for 5 years. If you want to switch to a bisphosphonate for a year or two, you can stop it. You still get some more improvement, or I should say more help there. The other problems, hypothyroid, gout, insomnia, fibromyalgia, sleep apnea, no change there. Now the MUGUS, that's a little more of a preventive. Are we looking for something? At what point do we say, we're going to quit looking? That's a shared decision. Osteoarthritis of her foot. You want to keep her mobile. You got to keep those feet from getting blisters. We're still following, make sure her shoes fit right. Incontinence. The atopic estrogen may be a little more difficult. Stressors. Just because there's dementia doesn't mean, seeing someone to talk about that will still help. Probably a little lower threshold for watching for depression here. And her osteoarthritis, I want to keep her out of the hands of surgeons with this at this point. Okay. Second case, 76-year-old with MCI, mild dementia. He's a Vietnam veteran. He has PTSD. He brings you pictures of Vietnam that his wife of 15 years didn't even know exists. PTSD is starting to bother him more. You see this more as cognition starts to drop. You can't compartmentalize things. Now, as a young man, he treated it with alcohol and adrenaline. He lived. He was a very successful man, worked hard. He still can't sit still. I think that's how he sort of treats his anxiety, by just staying busy, even now. He hangs out in his shop and the ER because he's in his shop accidents, and he has pictures of those too. Everything hurts. He has horrible hand arthritis, which is really debilitating for him. He has multiple new joints, from fast living. Severe restless legs. Takes about half a dozen propinerolls a day. AFib on a DOAC, hyperlipidemia. From his heart disease, he's had stents. Diabetes has actually gone away because he wanted to get dental implants and he's lost so much weight. And then one day he says the meds don't help. I don't take them. Oh, really? Now you tell me. Okay. Only the Repinerol because I feel better on that. He lives rural. It's a little harder to get things to him. He's not good at doing his paperwork, and he's not good at doing labs. All righty, that's what we have. Our treatment, we know what matters most to him. He likes staying busy. He wants to be in less pain and he wants less intrusive thoughts. Quality of life, the restless leg is the big issue for him. The chronic pain, that decreases his function with his arthritis and his PTSD. Now, as this provider, I'm thinking stroke from your AFib, you're not taking your meds. Hope you don't go back to your old treatment. This weight loss kind of worries me a little bit. Is it just the eating? There's always suicide in the back of my mind. And after we had our discussion, he said, yes, I want the Repinerol. That's an easy one. He was on the buprenorphine patch. Then we can increase that. We did talk him into the DOAC because of disability from stroke. Staying dry, he said, okay. He'll do the paperwork, and he nods his head at me. He likes staying active. That's not an issue. Trying to arrange a PTSD group. And one thing he mentioned that I've known him a while, he says, I didn't know existed. He has a horse. And that horse has gotten him through a lot of difficult times. Unfortunately, he can't care for it now because of his arthritis. So his granddaughter has it. And he says, I'm seeing my horse regularly now that the weather's better. That's good. Horses are good therapists. And we're going to stay in touch. Now, his heart disease, his neuropathy, said depression. He said, I don't feel any better on any of those things, so I'm just not going to take it. Okay, that's fine. We'll stay in touch. That's what matters most to him. Another case, late life, Mr. Alzheimer. Saw him in the fall, advanced Alzheimer's, hypothyroid, had PE 3 years ago, COPD. The caregiver burnout is very obvious on day one. Okay. He's on donepezil, T4, DOAC, amlodipine, the usual. He's very busy around the house. He does his own ADLs, no IDLs. His wife says he can pour a cup of coffee is all he can do. He's DNR. Well, that day, the donepezil, memantine aren't doing much. Meclozine's anticholinergic. Get rid of them. The fall goes reasonably well. You see him in January, and she says, I need a padded room. That's caregiver burnout. We start discussing statins, and at this point, they're probably not helping. And as you delve into the chart, you realize that the reason he's not on DOAC is not for some crazy reason why you need it forever and one day. It was just never stopped. So we need to pay attention to the high risk meds. So we stop that. Comes in again, knee pain. He's wandering at night, not sleeping as well. Added low dose trazodone, no deep prescribing. A knee injection is a pretty benign therapy to see if we can make him feel better. And then the palliative care consult, the wife was all in agreement. School counselor, 82. 4 years ago, he had mild dementia. Now he just sits in the office and smarts off to you with old vaudeville lies. He's DNR. He's always said he's been a DNR. He said, it's okay if I don't wake up. He wanders around, eats at night, probably because he's bored. He's cooperative and friendly. And he looked at me and said, Doc, you're an expert. X as in has been and spurt as in a grip under pressure. His wife's eyes got very big. She laughed, he laughed, I laughed, and I wrote it down so I wouldn't forget. Jerry Clinic is so much fun. He has diabetes, hypertension, seizures, they flutter, blah, blah, blah. You can see that. He's on a boatload of medicines, TID AccuChecks, but their view is his quality of life is good. He's very nice to him. He's pretty independent in his ADLs. And if anything goes wrong, they think it'll probably go wrong in a big way. So let's do everything we can to keep it where we're at. So we're not doing any changing, but these are all on the table for if things change. Our last case is someone you've all seen, the rural farmer that says, Mr. I am going to die here. 86-year-old lives on the farm. He was born there, raised his family there. He's a good community member. He presents the motive of about 16. He's active on the farm. His wife's not as good at health. She wants to move to an assisted living. He is physically fit and enjoys being out in the sun. The next 18 months, you're basically refereeing the disagreement of this, and he doesn't change very minimally. Well, now they've each had a fall. They can't get each other up. They've had to call for help, and she says, I'm leaving. I'm going to go to assisted living with close to my overwhelmed son. He's 88 now, and he's still physically fit. The son has now his guardian. Do you force him to move to the ALF, or do you arrange home health care to support him because he never wants to leave the farm? And not just now, but in the past, he said, if you find me in a snowbank or if you find me on the ground, that's okay with me. What do you guys think? Well, the son said, I'm going to support my dad's wishes, and saw what and thought and got going on mobilizing support. The first company to provide nursing said, we'll have nothing to do with this. It's a train wreck. Second one said, we'll give him 2 days a week. When he got people to bring in food, check on him every day. He called him every day. About a year later, he's getting a little owly with the people that are helping him give a bath. And another 4 months, 5 months later, he went to the nursing home without an argument. So I think the son, by granting his father what mattered most, really helped his quality of life. And mind you, he's a gregarious guy, so when someone came to visit him every day, that was good. Now, needing multiplexing invention, don't think of it as Wesley and Vizzini and their little, all right, where is the poison? We're not picking our poison. I think of it as a buffet. How big is your healthcare plate? How big is your appetite? How big are your eyes? What do you want to make this the most enjoyable? And I think about the Serenity Prayer. Give us strength to do change what we can change, and to accept what we cannot change, and the wisdom to know the difference. And thank you for your attention.